Okay, this is a lecture on neurologic disorders and medications, chapter 14. Most of the disorders in this textbook that it talks about treating are disorders that a neurologist is going to take care of, but that doesn't mean that you're not going to be involved somehow. I, as an acute care practitioner, you know, I don't manage neurological disorders, but there are plenty of things that I do become involved in somehow, or I need to know what those medications will do, to other medications that I want the patient to be on. So, for example, um, I typically don't manage people with seizures, but I have patients who do come to the hospital and it is a new onset of seizures. So by the time I've consulted the neurologist, I'm not going to let the patient just stay here and seize until the neurologist gets here. No, I'll start them on something. Of course, Dilantin, phenytoin in the hospital intravenously to start with. Those are good things. And then I'll go off of what the neurologist says. And also, I can start other diagnostic things like that. I've diagnosed multiple sclerosis here at the hospital, which is difficult to diagnose at the hospital. It's a long and drawn out process that really should be diagnosed on an outpatient basis, but it was a unique circumstance. But I did not initiate any therapy. That is purely for a neurologist to do. But again, many of those medications are important for you to be aware of. So again, this is chapter 14. You can review in the very first pages in 242 and 243. It really goes over neurotransmitters. You might refresh yourself. It's not going to be on the exam, but it might help you out with patho next semester. Remember, when it comes to neurological disorders, we're talking about the electrical activity of the brain, what's making the connection, what's not. In the case of a stroke, we're talking about the health of brain tissue, which I will say stroke is not in this chapter because that's a neurovascular disease, and I think we already covered that. Uh, yeah, so let's just leave it at that. I'm not going to muddy the water. Anyways, let's go ahead and skip on over to page 246. Seizure disorders. Okay, so again, this is not pathophysiology, so we're not going to go over just every little seizure. But of course, there are generalized seizures, partial seizures, absent seizures. The book on 246, there's a spotlight on convulsive status epilepticus. You should know about that, of course, because if someone comes to your office and they start having a seizure, and it happens, believe me, you're going to have to deal with it. Now remember, seizures are really, in today's thought, we want to terminate the seizure if we can, but in the meantime, we're worried about patient stability, maintaining their airway and that sort of thing. The seizure itself will not harm the patient as long as they're not done something during the seizure that would, as a side effect, cause harm. So, Valium, as you'll see on page on 246 in that blue box where it says Spotlight on Convulsive Status Epilepticus. Valium is a good, quick thing to terminate it, but it won't last long. I've used it a few times in the hospital when I was waiting on some Dilantin, but Dilantin or phenytoin is the number one stop it dead in its tracks. Of course, from the clinic, we're going to call the emergency department and get an ambulance. On page 247, the little box that talks about the hydantoins, that's phenytoin and fosphenytoin. The only difference is one is oral, one is IV. The main thing to know about these is this is the main thing that will stop a seizure, okay? All the medications I'm about to talk about have a similar mechanism of action, and it's all about stability, creating stability and the neurotransmitters in the brain along the axons and dendrites, membrane stabilization. Calm them down. They're too excited. That's why you're having seizures. Flip over to the next page, 248. Here we have tegretol and trileptal down into the, I guess that's about the third paragraph, middle of the page. Anyways, these are pretty versatile drugs. They can treat almost all types of seizures. They're pretty equivalent to phenytoin. The only difference is you can't dead stop a seizure with tegretol. Okay, so similar mechanism of action by calming out the neural membranes. So question for this kind of drug might be to the tune of patient is not having a status epilepticus, but they don't seem to be tolerating Dilantin very well. Which of the following would be a good alternative? Tegretol. Okay, and then skip on over to page 249 down at the bottom left or bottom right hand. Talks about miscellaneous anticonvulsants. Gamma aminobutyric acid. Man, I thought I was going to say it right. Inhibitors. These are a whole class of, or enhancers, I mean, a whole class of medications. There are, actually, just scratch that. When I was reading through this, I thought I was going to say something different. Now I've changed my mind. Actually, just look at the table on page 250. It's got a pretty good breakdown of various medications. These are medications that they work on seizures. We don't necessarily know how, or they're designed to treat something else, and as a side effect, they do help with seizures. So these are people with, maybe they're not tolerating other medications very well, or for whatever reason, they need to be on something else, or something needs to be added. Okay. Also on page 250 at the very bottom, and then mainly the main thing about seizures is going to be on page 251, and then it kind of finishes up at the top of page 252, spotlight on seizures. This really breaks down the types of seizures. Just review that. I won't test you on it because you'll get plenty of that in patho next semester. And then on table 14.2 is an excellent table for medications and types of seizures they treat. Now, I guess I better take that back. I'm not going to quiz you on, okay, the patient presents with these symptoms, what kind of seizure is it? But I may say which of these medications would best treat this kind of seizure, okay? So it's a little bit different, but those two tables are on the same page on 251, so it's right there. Study it. You'll be fine. Next section, this is really brief. Sleep aids. Most over-the-counter medications, their sleep component is diphenhydramine, Benadryl. But, of course, it talks about Lunesta and Ambien. I hate Ambien because it generally makes old people or elderly people go crazy, at least in my experience in the hospital. Use it with caution. Younger people doesn't seem to be a problem. But I always start with other things. In fact, we'll talk about another one in the next chapter that's actually an antidepressant, trazodone. It's actually a great sleep aid. I like that one a whole lot. That I don't think I'm even going to ask any questions about sleep aids. That's pretty straightforward. Then that's a brief section in the book, and next will be migraine headaches. So we're talking about Triptans. Triptans are excellent in terminating migraine headaches. Again, the thought is some sort of there's a neuromembrane instability as well as a neurovascular component that we believe causes migraines. So the triptans work on calming that down. Now, there are several different, on page 254, you've got the 1, 2, 3, 4, 5, 6, 7, 8 different triptan medications. I don't actually care so much about in the individual drug as you know what it will do for migraine headache. Now, the main thing is look down at the very bottom of that page in 254. It's all big capitalized. Remember, prescribing triptan drugs with selective serotonin reuptake inhibitors can cause serotonin syndrome. Now, here's the problem. You're about to find out because this chapter is neurology, the next is psychiatry. A lot of neurological and psychiatric issues do tend to run together, and it's because psychiatric issues are actual physiological disorders, and we're starting to make associations with other known physiological disorders, and you'll put this connection together on this quiz. If you don't, shame on you. You'll start to see, hey, wait a second. This one medication treats seizures, bipolar depression,